And I'm joined today by CMQCC's Medical Director and former Chief of OB at Cal Pacific Medical Center, Dr. Elliott Main. And we're going to be talking today about the various California statewide initiatives to support vaginal birth and reduce primary cesareans. Just before we get started, a few logistical items. Everyone has been muted, but please do feel free to ask questions through the chat or the QA lines, and we will try and get them as they come up, or at an appropriate time as they come up. And then if we do have time left at the end, we will open up the lines and we will take questions over the phone. So please feel free to wait for that time as well if you have any questions. So with that, let me introduce Dr. Elliott Main to get us started.
Good morning. Thank you, Ann. It is a pleasure to be here. This is one of a series of webinars that we're doing at CMQCC to promote a series of statewide efforts to really reinvigorate the efforts for supporting vaginal birth throughout the state of California, and indeed is having effects nationwide. What we're going to look at today is some of the very basic questions. Who is CMQCC? Why do we focus on C-sections? A slide or two on the different C-section measures, and then really talk about the statewide initiatives. And we're going to focus on three different pieces of it: the data center, the toolkit that's come out, the quality improvement toolkit, and the statewide quality collaborative that we have launched one wave of in May, and we're getting ready to launch an even bigger one in January. CMQCC is a multidisciplinary, multi-stakeholder collaborative in its own right that involves state agencies, the Department of Public Health, Medi-Cal, the Office of Vital Records, OSHPD, Covered California, a whole series of state programs there that are linked together and work very closely with the key professional organizations in maternity care in California. These include the California sections of ACOG, District 9 for ACOG, the California section for A1, the Nurse Midwife Organization, the Family Practice Organization, as well as the hospitals. And there's three regional hospital associations in California, one in San Diego, one in Southern California, and one in Northern and Central California, and then the statewide hospital association called CHA and HQI. They're key partners. But we also work extensively with the Pacific Business Group on Health, which represents purchasers, and then a series of leaders from our big systems and universities in the state of California, as well as public groups, and more recently, the health plans have begun working with us, and they are a key partner as well. CMQC was founded in 2006 as an outgrowth of CPQCC, the neonatal organization that was actually formed a decade earlier. CMQCC was formed initially with the recognition of elevated statewide maternal mortality and morbidity rates, and our focus in the first years has been on maternal mortality and morbidity reduction. We've also, because of our ability to collect large amounts of data, have been in the forefront of helping to validate and even develop a few maternal quality measures. But what our calling card has been in recent years is the deployment of large-scale quality improvement projects, 30 hospitals at a time, 60 hospitals at a time, and our latest one for hemorrhage and preeclampsia was 126 hospitals at a time. All these are anchored by our maternal data center, which gives rapid cycle feedback to hospitals, and we'll go over that in detail. So our working model of quality improvement is to start with a statewide multidisciplinary task force that develops a detailed game plan or a toolkit and implementation guides for how to do that, and then to do large-scale quality collaboratives around that toolkit. And these have often been adopted by other states, and right now, actually, a number of those have been adapted and then adopted nationally through the Council on Patient Safety and the National Safety Bundles. Examples of these include what we did with the March of Dimes very early on in 2010, the elimination of early elective delivery, and then 2 editions of our OB hemorrhage, because that was hugely popular in California and around the country, and followed by a response to preeclampsia as a quality improvement toolkit. Those being hemorrhage and preeclampsia being the 2 most preventable causes of maternal mortality. Attention's now turned by all the partners in the process in the collaborative toward particularly first birth cesarean deliveries. As you know, this has risen dramatically in the last 20 years, from 21 to 32%. Nationwide, 33% now, 32% in California for the total C-section rate. But even more dramatic has been the degree of variation among hospitals and among providers. This has gotten national play in a series of articles. This has gotten the most attention because it cited tenfold variation. This is among total C-section rates. You know, from the very lowest to the very highest. In California, we're seeing pretty similar numbers, not quite tenfold, but I'll show you that in a moment. But it raises the question of why we should care about C-section rates anyway. Well, we've seen the rise. You know, when I was, say, a resident in the early 1980s, it was under 20%. And everyone that I was trained by had been in hospitals with rates that were in the single digits. It is now, as I said, 33%, but with that rate, we have not seen a decline and improvement in neonatal outcomes. The cerebral palsy rates, the neonatal seizure rates, the asphyxia rates are unchanged since the 1980s. So it's hard to identify benefit for the baby in doing the ever-increasing C-section rate. 5 or 6 years ago, there were some articles that came out suggesting there might be some benefit for urinary continence, long-term urinary continence in the mother. These studies have actually been largely supplanted by other studies suggesting that the biggest driver for urinary continence when you're 50 or 60 is the number of pregnancies you've had, not the number of vaginal deliveries, and whether you are white race or smoker, and or have a family history of connective tissue weakness. Sort of like an episiotomy, which was also felt to be a protection for long-term urinary incontinence, it's looking like C-section is less of a protection there as well. We do know that C-sections per se are associated with increased maternal and neonatal morbidity, even when you correct for the maternal conditions that you're doing the C-section for. For example, there is no question that there's increased problems with neonatal respiratory function, absolutely big increase if there's no labor prior to the C-section, or if you're at a marginal gestational age, like 38 or even right at 39 weeks, that there's more NICU admissions, more difficulty with respiratory adaptation. Concerns about breastfeeding, concerns definitely increased infection rates, venous thromboembolism risks, and transfusion risks, things that you would see with any type of surgery. It is a longer recovery, and there's at least twice the rate of postpartum readmissions. Postpartum readmissions are a big deal in today's world, both for the woman and her family as well as for payers and reimbursements. The biggest issue, though, with C-sections is that prior C-sections can have major complications. That's the biggest risk. You know, there's not a high risk of major complications from the surgery itself, but as you start accumulating C-sections, the major complications arise, particularly placental implantation complications regarding previa and accreta. When I was a resident, there was, and then an attending at a university hospital over a 10-year period, we saw 1 accreta. in the 1980s. Now we're seeing an accreta every month in a university setting. This is a pretty significant complication. Let's ask about which C-section rates. So what has made it into the quality realm and what should we be focusing on? Total C-section rate is a bit complicated because it includes repeats and primaries. You know, we don't have much control over who comes to us with a prior C-section. We do, and that varies a lot from hospital to hospital, and that presents very different issues, medical legal issues about what your hospital's capabilities are. So the attention is really focused first and foremost on primary C-section rates, or their first C-section, but that includes both nullips and multips. And as we'll show in a moment, the rate of parity varies greatly from hospital to hospital. Multips have a 4 to 8-fold lower rate than a nullip, or conversely, we all wish that we could deliver multips. The NTSV rate is a risk-stratified nulliparous rate that is term singleton vertex, eliminating high-frequency complications that have high rates of C-section. So it doesn't, it's also called low-risk first-birth C-section. It's not all low-risk, that's a misnomer, but it gets rid of all the high-risk factors that have any kind of frequency over 0.5%. So this is the most commonly used one by NQF, by Joint Commission, by CMS, by Leapfrog, and the one that is used for public release in California. This slide shows the variation in nulliparity among all the hospitals in California. You're going to see a set of slides like these. These are, each bar represents a single hospital in California. The lowest rate of nulliparity is 23%, whereas at the other end of the scale, there are hospitals that are 50 to 60% of all their births are first births. So you could see that they would have a very different obstetric population if one hospital had twice as many first births as another hospital did. So this is the performance measure that's used nationally. Risk stratified, widely adopted. Been around a long time, 15 years, so we have a lot of experience with it. National Center for Health Statistics calculates this for every state in the country, and this is what Healthy Person 2010 and 2020 have used to develop their national targets. This is how that varies in California. This is 2015 data, so it's hot off the press, released last week. This is based on statewide data that every hospital has submitted. OSHMOD gets each hospital's discharge diagnosis file, so we link it with the birth certificate data to get parity in gestational age. And you can see that the hospitals range from 11 to 77%. Now there's some outliers at each end, but there's a goodly number of hospitals that are under 20%, and 42% are under the national target of 23.9. This has been a growing number in the last couple of years, from 35 to 40 to 42%. But there's still a lot of hospitals over 30 and over 40% of all the first birth mothers who come to them end up with a C-section. As we look at quality improvement strategies, we think back to what happened with early elective deliveries 5-6 years ago. That was a project that became a state and national project, and it actually changed practices pretty quickly. That happened because of what's called collaborative action leading to collective impact. So there were multiple pressure points brought to bear at the same time. There was performance measures that were publicly reported. There was a quality improvement toolkit. The ACOG, A1, ACNM all got on board. There was data-driven quality improvement initiatives. March of Dimes, CMQCC, Hospital Association all ran those. The health plans got engaged, Medicaid weighed in. In some states, they actually refused to pay for it. We did not have to do that in California, and I'm pleased about that. It's much better to do it more voluntary than what a number of other states have done. Purchasers and employers got engaged, and March of Dimes got the public engaged with PSAs and with patient education materials. This is the same strategy that is now being brought to bear for primary C-sections, particularly nulliparous primary C-sections, is mobilizing all of these actors with all of their resources at the same time. What we're going to talk about today is a variety of activities that are going on. The three that I mentioned at the beginning are the biggest ones, but I want to talk about some other supportive ones. ACOG, A1, ACNM are doing a speakers bureau, giving grand rounds, and meeting with leadership, nursing and administrative and physician leadership at hospitals to get them jump-started on doing QI. That's been set up, people are trained and out there doing it. There is a slide set for this that's available and for collaborative use. There is a regional labor support workshops. We'll talk about this a little bit more later, but this is led by midwives, doulas, nurse educators to refresh our nursing staff on the art of labor support. We're doing webinars, such as today, but in more detail on specific topics on nearly a monthly basis going forward. Last week in Sacramento, the state of California released the hospital rates for every hospital in the state for the NTSV rate. This is done through CHART or calhospitalcompare.org. On websites, you can find every hospital in California. Actually, there are other websites with this data, including one by the California Department of Insurance that covers HMOs and medical insurance that's done through UCSF and Consumers Union. There's been extensive media coverage of this with articles in San Diego, Sacramento, and I believe one's coming out shortly in Los Angeles. And last week, Secretary Dooley of the California Department of Health and Human Services, which oversees Medi-Cal and the Department of Public Health, did a joint press conference with the Hospital Association Pacific Business Group on a statewide project to reduce overuse in three areas, one of which was primary C-sections. In addition, Consumers Union, social media are getting engaged in this, and there are more patient education materials being developed. So calhospitalcompare.org is a consumer-facing website, and it was updated with 2015 data last week, and there were letters sent out to every hospital CEO in the state with their particular rate and how they stack up for these three measures, the NTSV C-section rate, the overall breastfeeding rate, and the episiotomy rate. CHART took the numbers and did statistical testing on them with a working group of statisticians from around the state to put them into categories of superior, average, below average, and poor. This is not what we do per se. Our goal is to actually improve the care, but it does make people sit up when they see themselves in different categories. So this is an interesting question. Who cares about the C-section rate? And as patients and women get educated, they start caring a whole lot more. The health plans and the purchases are now caring a lot as they start looking at the expenses from not only the first C-section, but all the subsequent C-sections. And covered California, which is the big health exchange in California, about a month ago sent out their new contract with all their affiliated health plans. That stated that by 2019, for hospitals to be included in their network, they need to have their NTSV C-section rate below 23.9. This is a bold move, and it's gotten both the health plans and the hospitals quite engaged on this subject. Now, obviously, if you're 45% rate right now, that may be a step challenging, though we've had hospitals drop from the low 30s to the low 20s within a year. This is a good 2 years off. But there is an exception. If you're actively working on the topic and you're showing improvement, they're not going to exclude you. So this is out there as a good wake-up call, if you would. And so a number of health plans are becoming more and more engaged on this, and including the big ones in Los Angeles, like LA Care, Molina, Blue Shield, are all integrating this into their QI projects for all their contractees. So every hospital's been notified of what their rate is currently. Actually, if you're part of the data center, you can know what your rate is last month or the last 2 months. But the question and the focus of today's session is, what can we do if our rate is above 23.9, or even if we want to lower it to 20 or 18? There are 3 ways that we're geared up to help you. The first and foremost is understanding what drives your cesarean birth rate. And we have the Rapid Cycle Maternal Data Center we're going to discuss in detail in a moment. And then we're going to go through the CMQCC toolkit for supporting vaginal births and reducing C-section that's been wonderfully reviewed, and the QI collaborative. So I'm going to turn this over to Anne to work on the data center.
Hey. Hi, everyone. Go ahead and go to the next slide, please. Okay. So I'm the program manager for the Maternal Data Center, and together with our technical team and our data specialist, Amanda Woods, know that we're always here to help you out if you either decide to initiate participation in the Maternal Data Center, or you just need some extra help if you're already participating. What is the Maternal Data Center? It is a secure online tool to which hospitals submit data, and then our tool will automatically spit out a whole bunch of performance metrics, benchmarking comparisons, provider-level metrics, measure analysis tools to help you identify quality improvement activities, and risk-adjusted measures, all in the service of helping your hospital to drive quality improvement. Now, what's unique about the Maternal Data Center that is different from what you are probably already doing through your Joint Commission core measure vendor, or maybe even through some of your internal databases, if you have them, is that the tool has specifically been designed to support quality improvement. A core measure vendor system is very good at generating an overall performance metric for reporting to the Joint Commission, but hospitals are often left with, well, what do we do next? We know that we have this rate. How do we go about reducing that rate or improving upon that rate? And the Maternal Data Center, as designed by Dr. Main, who's a former chair of OB and who knows that it's very important to have data to drive improvement, really helps to fill in that gap about what do we do. Next slide, please. Okay. Over 200 hospitals have already joined the Maternal Data Center. We're actually serving hospitals in, technically it's 5 different states now. We started off in California, but over the last couple of years have also rolled out to Oregon, Washington, and even have a couple of Alaska and Montana hospitals that participate. Okay, here in California, we now have over 180 hospitals that are actively submitting data to the Maternal Data Center, and that represents 82% of California's delivery volume. So we're really covering a very large swath of the state at this point in terms of the comparative data that we have in the data center. Next slide, please. How does it work? Okay. Our goal is to give you tools for your quality improvement while minimizing your data collection burden. We know that you don't have a lot of extra time when you're managing a busy clinical department or a busy quality and risk management department. So we very much want to minimize your data collection burden while giving you as much information as you need to support your quality improvement. How do we do this? One key step is back in 2011, we created a partnership with the California Department of Vital Records in which they send to us on a monthly basis, 45 days after the end of each month, birth certificate data for all births in California. Now, the original source of that birth certificate data is your hospital, okay? And then it gets sent to Vital Records, and then it makes its way to the Maternal Data Center, where we upload it automatically into your hospital account. What's important about having this birth certificate data that really minimizes your data collection burden is the fact that it has key data elements that aren't captured in a typical patient discharge data set. For example, gestational age, parity, birth weight, APGAR score, and very importantly for calculating provider level metrics, it includes the license number of the provider that performs the delivery. And in that way, by bringing in this birth certificate data, we can really ease the data collection burden. Okay, so we bring that in automatically, so there's no additional burden for your hospital with respect to the birth certificate data. You just keep on doing what you're already doing, which is having the birth clerks collect the data and put it into the regular Vital Records reporting system. Okay. The second piece of this is patient discharge data. Now, these are data that are already being collected and reported by your hospital to a different state agency called OSHPD, the Office of Statewide Health Planning and Development. Okay. You're already collecting these data. When you decide to start participating in the Maternal Data Center, you simply run these patient discharge data on a more timely, more frequent basis and directly upload them into the Maternal Data Center. The Data Center tool will automatically link those patient discharge data and all the ICD-9, ICD-10 codes that are already included in them, gets linked to the birth certificate data with those key data elements of gestational age and parity and provider license number, and then we can automatically calculate a whole host of metrics and measure analysis tools for use by your hospital. Okay. There are some measures that do need some minimal additional data entry. Usually it's less than 1 hour per month, or if, I want to put the emphasis on if you want to calculate those measures, because from our perspective, these measures are optional, and it's up to your hospital to decide which areas you want to focus on and which measures that might need a little bit of extra chart review you want to spend your resources on. And so that is totally up to your hospital. But over 80% of our measures get auto-calculated within the Maternal Data Center based simply on the discharge data that you submit being linked to the birth certificate data that we import in from Vital Records. Okay. We're linking close to 1 million mom and baby records per year. Next slide, please. Okay, so what do you get? Okay, first and foremost, I want to mention this is a secure online tool. Your hospital decides whom amongst your employees will have access to the tool. It is completely within your control in terms of who has access to the data. So it's those people at your hospital that you've authorized and CMQCC staff, and that's it. It's confidential for you unless you specifically authorize us to transfer data out to a third party on your behalf, but we would need a specific authorization for you. Okay. When you submit these data to the tool, then as you can see, this is the home page you would get for your hospital. You get up to 33 different hospital clinical performance measures. Again, many of them automatically calculated based on your submission of patient discharge data on a monthly basis, okay? We have hospital data quality measures because we recognize that a lot of times your performance on these measures are based just as much on the quality of your coded data as they are on actual clinical practice. So we help you identify inconsistencies in your coding that you may want to investigate and work on as well with your coding staff and with provider documentation. Data quality is extremely important to make sure you are generating the right result. We have provider performance measures. We can automatically, again, based on that discharge data you submit, auto-calculate 10 provider-level clinical quality measures so you can see variation across your providers. I'll show you what that looks like now. And then if you participate in any of our collaboratives, currently we'll be talking a lot more about this in a few minutes, our C-section collaborative, there are a special set of measures that really help hospitals with their primary C-section reduction activities. So there's a special section for that. And then a whole bunch of hospital statistics that folks even outside the L&D department find very useful. What's average length of stay for vaginal versus cesarean deliveries? What's your monthly delivery volume? What are your payer statistics? So how do payer statistics for NTSV C-section compare? Lots and lots of different just general statistics that are very handy to have for leadership at the click of a button, really. Next slide, please. Okay. Currently, it says 32 hospital clinical quality measures. We're actually up to 33 now. Whenever there is a vetted and validated quality measure that we can calculate in the maternal data center, we will add on to it. So we're actually up to 33 now. Today, I'm going to be talking specifically about the NTSV C-section measure. So you see on this screen, this is our summary screen, and in fact, it's a cutoff version of our summary screen. There are even more that are listed below it. But we're going to be talking about the functionality of the tool with respect to the NTSV C-section measure, but know that the same functionality exists for every single one of the 33 hospital clinical quality measures. Next slide, please. First thing you do, if you were to click into any of those measures, okay, you would see a run chart that shows your hospital's performance over time, going back to 2011. Okay, you can very easily change the way you display this graphic, so you can see it, the data on a monthly basis, on a quarterly basis, on an annual basis, and with just a click of a button, you can very easily download the graphical images into a .png file, so you can copy and paste it into a PowerPoint, send it to a colleague via email, or you can very easily, again, with a single button click, download the data into an Excel spreadsheet so you can manipulate it on your own and play with it on your own. Next slide, please. Okay. This is the real power of the tool, though. From that hospital trend screen that we just saw, if you were to click on your rate for any one of the reporting periods, you would immediately be taken to a screen that shows you your patient-level drill-down information. Specifically, you'd see whom amongst your cases ended up being fallouts for that measure. And then you'd be able to click on the denominator case tab and see who fell within the denominator. And in fact, just last week, we added a third tab to the screen where you can see all of the cases that were just out and out excluded from the measure population. What does this help you do? So for this particular measure, what we're seeing is among those women that were nulliparous term singleton vertex cases, which ones of those ended up having a cesarean section, and those are your fallout cases. On this patient-level drill-down screen, you're able to see the patient's medical record number or account number, the delivery date, all the diagnosis codes, and as you hover your cursor over each of those diagnosis codes, you're able to see the exact description of that code. So you do not need to have your ICD-10 coding manual handy. You just pass your cursor right over the code, and a hover box will pop up that shows you exactly what that code represents. You also see birth weight, gestational age, whether the case had been induced or not, and the name of the provider that performed the delivery. You can make comments in this as you are reviewing these cases to identify quality improvement opportunities. You can print this out, and you can download it into an Excel spreadsheet or a .csv file, again, for you to manipulate on your own. Next slide, please. Okay. If you are part of a system, a multi-hospital system, this tool will automatically allow you to see all of the hospital rates within your system on a single comparative graph. So if you're a Dignity Health Hospital or an Adventist Health Hospital or a Prime Hospital system, there's a single click to the system comparison screen lets you see not only your hospital's rate for a certain period of time, but that of all of your sister institutions. And this is very useful for not only your own hospitals and any kind of friendly competition that you might have with your sister institutions, but also for your system leadership. Okay. We show these kinds of graphics, not only the system-wide, but also you can see it compared to your region, to your NICU level, lots and lots of different graphics. And you can customize the reporting period on these graphics as well. So you can choose any reporting period that you want to display. Next slide. Okay. This is a brand new feature that we rolled out that, we think folks are going to be very excited about. This is a set of bar graphs that shows your hospital's performance in the context of the performance of every other hospital in California or every other hospital participating in the maternal data center. So even those Oregon, Washington, Alaska, and Montana hospitals that I showed you. Okay. Basically, each of these vertical bars represents a specific hospital's rate. Now, you only know which of those bars is your hospital. Okay, all of the other rates are masked, so you don't know which bar represents which hospital. Again, it is a confidential tool, but this gives you a sense of your hospital's performance relative to all the other hospitals in the state. And what's really fun about this tool, if you wanted to take a look at, for example, only the hospitals in your region, only the hospitals that have the same nursery level you do, only the hospitals in your system, you would be able to change the display so that you only see vertical bars for that choice. And you can do highlighting to, for example, highlight your other sister institutions on this chart. It also, you'll see the numbers at the very bottom. We not only show you the graphic, but we show your exact position in the graphic relative to everyone else, what your percentile ranking is. You don't see it on this screen, but your mean, the average across everyone, and where you stand in relationship to the Healthy People 2020 target rate of 23.9%. Next slide, please. The provider level metrics has proven to be one of our more popular features in the maternal data center. This is where you just, again, click on the by provider display, and you can see for 10 different clinical quality metrics, provider-specific rates for that particular measure. Along with your hospital's average rate, which shows up as the bright red. So this is a really easy way to assess the extent of variation for any one of these measures at your hospital. And again, it's for your confidential use. It may be that there are very good reasons for certain providers having higher NTSV cesarean delivery rates than others. Maybe they're maternal fetal medicine specialists. They do, in fact, get all the the high-risk cases. That's information where you can use this information accordingly within your own facility. And we don't show it here, but you would be able to click into any of these provider level numbers, okay, or names. You have the choice to display this by provider name and not just by number. Okay, you'd have the choice to click into any one of those provider names and actually generate individual provider-specific reports for your providers so that you could distribute them on a confidential basis in order to provide that feedback to your providers as you see appropriate. Next slide, please. Okay. Lastly, and again, this is a very unique feature of the tool, we have some measure analysis tools where we take the overall performance measure, again in this case, the NTSV C-section rate, and then we parse it out into these subcategories so that you can identify the specific drivers of the cesarean delivery rate. So for example, okay, you see here for Demo Hospital, they had an overall NTSV C-section rate of 34.1%, but then we parse it out for you so you can see what the rate was for your population that started off in spontaneous labor versus the rate for your population that started off with an induction versus that population that actually went right to a cesarean delivery. Okay? And then we show it to you in relationship to the averages for each of those subpopulations for the hospitals that are your same nursery level, whether you're a basic, community, regional nursery. So you can compare your hospital's spontaneous labor NTSV C-section rate compared to that for other hospitals that have community level nurseries and other hospitals statewide. And this helps to give you a sense of whether your practices for that particular subgroup of patients is comparable to what's going on statewide and other hospitals equivalent in terms of the types of care, with the nursery level being a proxy for the level of risk of patients that you serve. Next slide, please. Okay. The tool also recently has given you the ability to assess the impact of quality improvement interventions using control charts. So again, you can track your performance over time, and then if you initiate a QI intervention and then you see that progress is being made, then you can annotate directly into the screen as to when your QI intervention began. You can determine when it stabilized, and you can see if your QI intervention did in fact have an impact on your rates, and you can gauge that from a statistical, using these statistical tools. Next slide, please. Okay. So, I know many of you on the call are already participating in the CMQCC Maternal Data Center. If you're not, but you are interested in joining us, then it's quite an easy process to initiate. First, we do have a participation agreement. You would be submitting patient discharge data directly into the online tool, so we have a legal agreement that includes a business associate agreement that basically is in full, sets out all those HIPAA compliant standards that everyone needs to take care of. And so we have a standard agreement, and as soon as you're ready, we would be happy to email you our standard agreement for review by your institution. Okay. Second step is submitting patient discharge data. Again, these are data that your hospital already has in-house. Every single California hospital is already mandated to report patient discharge data to that state agency, OSHBD. Okay. The only difference between you're taking that PDD and submitting it to OSHBD and what you do for the Maternal Data Center is ideally, okay, when you submit to OSHBD, you only submit every 6 months, and you support on very long time lags in relationship to when the care actually took place. Okay, you take that same programming in place for generating your OSHBD PDD file, but you run that program more frequently, more timely, and submit it directly to the Maternal Data Center. So we're leveraging the fact that you already have these data in-house and already have a report written in order to submit to that state agency. It's just a matter of running it again on a more timely, more frequent basis for submission direct to the Maternal Data Center. Okay? And then lastly, once you have patient discharge data submitted to the Maternal Data Center, then we hold a training session for you and your team so that we can talk about your performance metrics and your quality improvement opportunities in the context of having your data in the Maternal Data Center. Really, this tool is about helping you advance your hospital's quality agenda. And so with that, go ahead and go to the next slide, and I think this is where I turn it back to Dr. Main.
Thank you, Ann. The data center is really a very powerful quality improvement tool that is an incredible support for projects that we're going to be talking about next. The first one is the toolkit. And the toolkit is a set of best practices in key elements that we'd like to integrate into labor and delivery function. And it was written by a group of nurses, physicians, doulas, and midwives from all around the state of California. So it's basically a how-to guide for supporting vaginal birth and reducing C-sections. It is a resource foundation for our collaboratives, but it's actually really good reading regardless. So we've had an incredible rate of downloads in the first couple of months, well over 2,000 for the full toolkit. It's available for free on our website. It also importantly has a companion, very short implementation guides about what you do first, and we're going to go through that just a little bit. So over 50 experts in maternity care from California and a few national leaders as well either wrote the elements or reviewed them and advised them, and these include leadership from the American College of OBGYN, from College of Nurse Midwives, from the Nursing Association, AWON, the California Hospital Association, Childbirth Connections, Blue Shield, Beta Healthcare. Beta is a medical malpractice group, as well as leaders from Sutter, Kaiser, Memorial Care, and various universities. We had a lot of input also from doulas and Lamaze. And it was really an interesting process to go through that. And we found a lot of consensus, actually, among those groups. The foundational materials for the medical part of it, the diagnosis of labor abnormalities and the what to do are drawn directly from national guidelines, including ones produced by the American College of OBGYN and the Society of Maternal Fetal Medicine, which came out in March of 2014, and the National Safety Bundle on Safe Reduction of Primary C-sections that came out just a few months ago. This is a pretty comprehensive guide, and we were very pleased to get a very strong letter of support from the American College of OBGYN. And I'm just blowing up some of the statements within this letter. This is from the CEO and the Vice President for Practice Activities for the American College, saying that we've had the honor to review this comprehensive toolkit and strongly supports its dissemination and use. And later on, they say this excellent resource in the plan for encouraging awareness implementation is unquestionably a commendable program and sets a benchmark for achieving success. So we were thrilled to get this because obviously our physician colleagues want to hear that this is something that the American College would support. At the same time, actually, 10 days ago, I had the honor of being in West Palm Beach, and we got an award from Lamaze. This is me in the middle there. And it's sort of a statement that you can create a toolkit that will get awards both from the American College of OBGYN and from Lamaze. That's almost unheard of. But this is an area that we actually are creating a fair amount of consensus in. The toolkit does mirror the National Safety Bundle with a lot of materials, best practices, tools, examples of policies, procedures, etc., educational materials about readiness, recognition, response, and reporting. Actually, tomorrow, Dr. LeGroux has another webinar scheduled that's going through the toolkit in great detail, but I'm going to give you an overview right now. Recognition, for example, is about early labor support, the role of doulas, intermittent monitoring, which is strongly supported by ACOG, actually, and the best practices for epidural analgesia. A response here in the middle is having a standard response to abnormal fetal heart rates, so everybody isn't just winging it on their own. But importantly, it has standard definitions for labor abnormalities and uses the new ACOG guidelines for approaches to labor dystocia or for managing induction of labor. It's important that everybody pays attention to data and reporting systems, and that's what the last section is on. Each of these sections has multiple examples and case studies, diagrams and references. We actually have a fifth part of the bundle, which is case studies from hospitals that have reduced their C-section rate, and this is actually basically how they did it, and that's been very useful for folks. Examples of some of the best practices in here is a new modern active labor partogram with 3 parts to it: normal labor progress, the yellow zone when you should be considering interventions, and then those when you should be making your delivery plan. Note this starts at 6 centimeters. We discussed the peanut ball and how to use it, and a variety of other techniques, both for women with and without epidural analgesia. Everybody's talking about shared decision-making. But what does that really mean? And we have a number of tools from ARC and elsewhere, national tools that help explain how you actually do shared decision-making in obstetrics and and how that can help. There are lots of best practices in the toolkit, and we realized pretty early on that we had to do some focus. What are the top 10 most important ones that you should think about? If your hospital hasn't already done these, these would be some of the ones that we recommend that you do first. For readiness, it's really building a team and developing a program for ongoing staff training for labor support, and developing positive messaging. For recognition and prevention, the two most important things are implementing protocols and support tools for women who present early in labor, 1 or 2 or 3 centimeters. And the next one is having protocols and encouraging movement in labor and intermittent monitoring for low-risk women. These are both changes in practice that we really need to bring about. Response, the top 2 of our total of top 10 is having standard criteria for diagnosis and treatment of dystocia, and having the ability for folks to recognize malpositions, particularly OP presentation, which is the scourge of labor in a nullip. And there are some interventions and positioning that can be helpful for helping resolve that. And reporting, what we have seen again and again around the state is the importance of sharing provider-level data. We do this only restricted to the hospital, but it's very useful within the hospital to share this on a regular basis, not every month, but at least every quarter as numbers build up. so that providers get to see where they stand compared to their peers locally and beyond. One of the tools that Ann showed was the ability to look at cases to see whether they followed or fell out from the ACOG checklist. So these were whether you succeeded in following the checklist for dystocia or for labor induction. And lastly, you need to have a good communications plan in your hospital for any QI project, and this is not an exception. So we're going to have a deeper dive in the toolkit tomorrow with David LeGroux, one of the toolkit editors, and that's again open and will be recorded, as this one will be, for future viewing as well. So the third key action step is joining the Supporting Vaginal Birth Reducing Primary C-Section Collaborative. As you can see, we're really trying to frame this positively. This is not all about reducing C-sections. This is really more about supporting vaginal birth and doing a great job of that side of it, and then the C-sections will fall into place. We have 2 rounds of participation. One kicked off at the end of May in Los Angeles with 30 hospitals. We have a second round that's going to kick off in January, both in Southern and Northern California. We have essentially every hospital in San Diego joining this round, and we have a number of other hospitals in both Northern and Southern California. We are using the mentor model for collaborative work. The mentor model includes a nurse and physician pair that help facilitate quality improvement. And maybe a little mentoring, but it's really about facilitating the change management with smaller groups of hospitals of 5 to 8, as opposed to bigger groups of 60 where you might get lost in the shuffle. We do, though, want everybody to get together, representatives from each hospital at least twice in the collaborative. The collaborative will be at least a year. Because that's a way that people can share their experiences and learn from each other, because that's actually one of the strengths of a collaborative. We have support for a minimum of 65 hospitals from California Healthcare Foundation. We're pretty close to the enrollment target, but we have money to do considerably more, additional funds from other sources, and we're particularly want to recruit hospitals that have higher rate in above 23.9%. The advantages of the collaborative is that you really get to understand and use all the features of the data center. You have the mentor support for implementation of the bundles in smaller groups, but at the same time you have access to national and local experts through Grand Rounds and our virtual education, as well as the monthly mentor calls. The mentor model we use for the hemorrhage and preeclampsia collaborative is 126 hospitals over the last year and a half, 2 years, and was widely reviewed as a strong positive for helping people through a challenging quality improvement project with really very exciting success. So in the mentor model, we have monthly web-based meetings with those 5 or 6 hospitals and your 2 mentors. Nurses understand nursing and physicians understand physician issues, so we really like to have the both of them working together. So each of the teams would report out what they were doing and share that with each other within the collaborative. There's no cost to participate. We're supported by the California Healthcare Foundation. The hospitals will provide the internal resources for success, including identifying your champions, time for the quality improvement team to work on implementation, education, and data analysis. Those are, of course, internal. Please contact the information about joining is on our website at cmqcc.org. Valerie Cape is the manager of that project. And we're looking forward to that. We'll post those at the very end of the session. We'll put everybody's contact information up. So your hospital needs to have a physician champion, a nursing champion, and ideally an administration champion, and those are all sort of key first steps to mobilize. You know, some people still wonder, why do I still need to do it in a collaborative? Peer-to-peer learning is actually a very powerful tool. It's the best way to improve even further and faster. It was pioneered by the Institute for Healthcare Improvement, IHI. We've taken that a step further with the mentor model and scaling it down as well as scaling it up. And the collaboratives really translate the knowledge of what to do into how to do it. And it makes things go faster because you're really getting the practical advice from peers. And it actually, the monthly calls really keep you on target, and it really helps integrate it into the workflow of the unit. We had 3 pilot projects that did this the year before. So these are tools that have been tested. So these were 3 Southern California hospitals, all with rates above 30%, or at around 30%. They use the data center. They use a prototype of the toolkit with the physician and nursing education. Toolkit is a lot more robust now than it was then. But it was sharing ideas, best practices. We worked with them on a regular basis. There was employer and payer interest in this area because the rates are very high in the LA area. And for each of the 3 hospitals, 1 payer negotiated a blended payment, though it took 9 months to do that negotiation, and most of the quality improvement work was done by that point, to be honest. But nonetheless, there was in the air that there was going to be a blended payment, i.e. that they could pay more for a vaginal birth, the hospital would, and a little less for a C-section, but that was only for about 5 to 8% of the patients with the 1 payer. So this is one of the hospitals, and this is the time course with them. It started January in 2014, and quickly, within a few months, they actually had a pretty dramatic change, and they were able to keep it sustained. All 3 hospitals had a 20% reduction. As you can see, baseline was 32%, 31%, 27%, and they all dropped by 6 percentage points, give or take, 5 to 6 percentage points, and have sustained that now. So this has led us to really scale this up now to a much larger basis now that we're trying to do this statewide. Any downsides? Whenever you do a quality improvement project, you really want to be sure that you're not leading to any unintended harm. So you have to have balancing measures, and this is where the data center can be very important, is that you can identify areas that you want to be sure you don't have unintended harm. For example, if we have a lot more vaginal births, are we going to have more 3rd and 4th degree lacerations? We could test that with our 3 pilot hospitals, and there was 0 change from the prior 4 years of baseline in their 3rd or 4th degree lacerations. However, the most important outcome for birth is a healthy baby. And we do have an NQF endorsed measure called unexpected newborn complications, which is essentially term baby outcomes among babies that had no pre-existing conditions, were normally grown at term, no birth defects, no maternal drug use, etc. So these are babies that were expected to have normal outcomes, and we were asking how many of them had complications or conditions that would that they would have ended up in a NICU, diagnoses or procedures typical of a NICU, and we divided them into severe and moderate levels. We found no change in the 3 hospitals' rates. In fact, one of the hospitals had significant improvement of their term baby outcomes, but none had a worsening. So the 3 key components that we want you to consider for helping you reduce your primary C-section rate by supporting vaginal birth are the data center, the toolkit, and the collaborative. Again, we have webinars, one tomorrow about the toolkit, but we will have continuing webinars about specific best practices throughout the year. We have the Speakers Bureau to get you jump-started with ACOG and A1 partnership coming to your hospital and helping get your teams going. We have labor support workshops. These are now around the state, 6 all-day sessions. There's only a few slots left. We're training 75 nurses at a time in these 6 sessions. Please sign up online, again, at cmqcc.org. If there's demand, and we suspect there will be a lot of demand, we will have more set up in the new year. These are meant to be train the trainers. So we have nurses, midwives, and doulas helping train nurses to be better labor support folks. I want to re-emphasize that Cover California has made this a contract requirement for hospitals to participate by 2019. So you don't want to wait to the last moment, so to speak, to help start working on that. DHCS, or Medi-Cal, has made this a quality project for their prime hospitals, which are the county, district, and university hospitals. And Blue Shield and the managed care companies in Los Angeles, particularly LA Care, are also moving in this direction. The transparency effort is well underway with the release just last week of all this, and it's in a number of the newspapers around the state, as well as being sent by Secretary Dooley to every hospital CEO in the state of California. So we're going to stop now and take questions. Ann Castles and Amanda are the key contacts for the data center, Valerie Cape for the collaborative. The toolkit is online. You can download it with just a simple registration so we can send you updates when things change. Nancy Peterson is the key person for that. And you'll find all of this at cmqcc.org. So thank you, and let's open the phone lines.
Okay, we will be unmuting everyone, so be aware of conversations in the background.
At
okay, so it's a little hard to hear. There was a lot of shakiness in the voice. If you could try again.
This is Debbie Gross at El Camino Hospital, and I know that you said the next collaborative is in January. Do you have the specific date?
That is the kickoff meetings are being set there. Oh, shoot. Debbie, why don't you email Valerie Cape and she'll give you the exact dates. We have one in the north and one in the south, and
okay,
maybe even a third one.
Okay, thank you.
I know the one in the north is going to be in the East Bay, and we have one scheduled in San Diego, and then they're in the second and third weeks of January.
Okay.
Dr. Main, this is Andrea Puck I'm at El Camino now. I have a question about the intermittent fetal monitoring. ACOG never really defined how to do that. I heard that they were going to be coming out with a new guideline soon. Have they come out with a definition of intermittent monitoring?
I think what they are using as the A1 definitions, and we have a number of materials on that in the website, as well as policies and procedures, because that's really the key piece for intermittent monitoring is who you monitor, how you monitor, and the details of it. So there is a lot of the details in the toolkit, and I would direct you there, and if not, we have some key experts on intermittent monitoring, of which I am not one, who can help you on that.
Elliott, this is Lynn Lee from El Camino Hospital as well. I have 2 points. One was I didn't see ectopic being one of the downsides to many cesarean sections. Is that still the case?
I'm sorry. What was the downside for?
I didn't see ectopic pregnancy being one of the downsides. You'd mentioned uterine rupture. You'd mentioned. Sure. Could you answer that for me, please?
Well, there's a lot of less common potential complications in which the literature isn't as clear. Anytime you have an infection after surgery in the pelvis, you have the potential for adhesions, and adhesions can affect your fertility, can affect your potential blockage of the tubes, which could lead to ectopic pregnancies, and there is some evidence that women who have C-sections have a little higher rate of fertility issues after that, but it's largely related to whether there's infection or not. It's sort of like any pelvic infection. The most classic one being appendicitis is associated with both ectopics and infertility. So that's really the intermediate one, but that's not a big one that I talk about, though that is in the literature. We're trying to hit the bigger ones.
And then the other point I have to make, and I've been trying very hard for 6 years to have introduced nitrous oxide to El Camino. I worked for 10 years with it in England, and I really think it's something that a hospital would benefit from. Is there any possibility we could add this to the toolkit to aid our infection of nitrous? The value of a collaborative is that you get to share best practices from around the state and even around the country. There are several hospitals in the state that are using nitrous. It has its own infrastructure that you have to have. It's not a simple thing. You can't just go out and do it. But it has policies and procedures and things to get underway. But, UCSF is one of the leaders in the country of that, and we'll have potentially a speaker on that. But it isn't a simple thing to introduce, many steps, but it has been is something that some people have found value. It varies as to whether it puts off, say, the use of an epidural or replaces the use of an epidural. It's certainly very powerful for multips to get through because it's a shorter labor, and they don't need as much potential help as a nullip may. So it's part of the armamentarium that I think could be considered, but it isn't a simple introduction piece. Okay, thank you.
So Andrea Puck was asking about slide decks. If you could write Valerie Cape, she can send that back. Or, yeah. So this slide set is actually pretty similar to the one that we are using in the Speakers Bureau, and this is available will be posted on the web as well.
Any other questions? Okay. If there are no other questions, we'll go ahead and wrap it up. Thanks to everyone who took your time today, and please don't hesitate to reach out to us if there are any other follow-up questions at all about any of our programs.
Thank you.
Thank you all.
Thank you.